manual, throughout the manual, there's different body systems, different categories, but within those body systems and categories, it's as if the same approach is happening just to different organs. And when I say the same approach, meaning um, like excision, repair, incision, those type things. Those are what we are looking for. Okay, that's what you're looking for. So the digestive system starts from the mouth and all the way to the abdomen, which is on page 264. And as you can see on page 261, right now I am looking at the reference pages in the digestive system. So I am on page 261. Okay, and I'm looking at lips on page 261. And for procedures on the lips, you can see it's either going to be an excision, a repair, or other, right? Excision, repair, or other. And as you can see, as you get to the vestibule of the mouth and the tongue and the dentoalveolar structures, the palate, salivary glands, you'll see it's the same procedures. So if I was going to ask what the first step or what the first step should be, you would know, okay, I need to know what the body part is, right? So with the digestive system, turn to page 262. For the most part in the digestive system, when you think about surgeries with the digestive, it's usually going to be more of like gastrectomies, procedures on the stomach, lots of procedures with EGDs, which is performed on the esophagus, which starts on page, let's see, that goes to page, it starts on page 269. And then you are, for sure, I can tell you, in reference to the concepts that they like to question you on the exam, you'll have something in reference to the appendix, for sure, your colon, right? And even the anus, right? Could be destruction, it could be hemorrhoids, right? Hemorrhoidectomy, also procedures on the liver, could be a liver wedge resection. And then they talk about the biliary tract. And then on page 264, you'll see there's procedures for pancreas and the abdomen, right? And so page 264 also has a blank, like there's only half a page. So that may be a good place to write your need to knows for the digestive system. Okay. So I'm just looking at some of the terms here. Gastroenterology, ology is the study, gastro-stomach, right? So study of the stomach. Digestion, these are just terms you're going to hear. Absorptions or mastication, just chewing. Okay. This slide or this particular PowerPoint, please remember that I will be sending it out to you. This is a great slide right here. I am going to want you to actually, when I send the PowerPoint, to take the slide, find a nice page in the digestive area, and write down what can be found in each quadrant, right? So to the left, if you're sitting in front of the computer screen, to the left upper, you'll see left upper quadrant. RUQ stands for right upper quadrant. RLQ, right lower quadrant, and LLQ, left lower quadrant. So these quadrants are explaining to you what can be found in each, right? And what you see highlighted in yellow or in gold are the main ones I want to make sure that you know. So it's great if you're able to put this diagram or put these sections of what can be found in your book, because when it comes to anesthesia, when it's time to code for anesthesia, sometimes they'll say that person came in and they had an appendectomy, right? So we can see that an appendix is located in the right lower quadrant, but in the anesthesia section, it won't say appendix or it won't say right lower quadrant. You're going to have to know where it's located for the anesthesia, and it's either going to be an upper or lower abdomen, right? So now we can see our LQ is going to be in the lower abdomen. So it's important that you have this particular slide or the information that has been provided on the slide written somewhere in the digestive system. Okay, and I'm just looking how they have it in, yeah, so in anesthesia, if you flip back a second for me, guys, if you could turn to page 58 in your CPT, keep your hand where it is on page 265, but turn back to page 58. That's anesthesia, and we're going to cover that a little later this evening. But if you're looking on page page 58, you will see upper abdomen and lower abdomen, right? So one of the things I want you to do once you get the slide is that you can see the organs or the body parts that are located in the upper abdomen on the slide, and you can see the ones that are located in the lower. We don't want any confusion when it comes test time. So if I'm talking about a gallbladder removal, right? Then you can see all you have to choose from is upper and lower abdomen. But if I'm looking at my slide, I can see that the gallbladder is in the right upper quadrant. So I know it would be in the upper abdomen. Same thing for the lower abdomen. Okay, appendix would be in the lower abdomen. So when you start writing your notes, even in the anesthesia, I would put right where it says upper abdomen, I'd put the body parts somewhere where I can know that those parts belong to the upper abdomen. So if I see the word gallbladder and I'm being asked to code for anesthesia, I would know that the gallbladder is located in the upper abdomen. Does everyone understand where I'm going with that? Okay, great. Okay, good. So I am back now to page 265. Okay. And we just spoke about the digestive system starting from the lips or the mouth, ending at the anus. Now, I will tell you in reference to any dental, there will be no dental coding on or, procedures for dental coding on the CPC exam. And then you can see the pharynx, and there's three components of the pharynx. You have the nasopharynx, the oropharynx, and the laryngopharynx. And this is just, I'm not on a particular page in the CPT right now. I am just basically just reiterating what you see on the slide. And the esophagus, there's going to be quite a few procedures performed that can be performed on the esophagus. They're called EGDs. Right? Well, that's when they enter a scope to see the three portions. Okay, and the esophagus is how food maneuvers to the stomach. Okay, and so the fundus is like the body of the stomach. The fundus, it's the body. And also remember, guys, that you do have your ICD-10, and within the ICD-10, you do have diagrams for each or illustrations for each of the body systems. So please make sure that you utilize your resources as far as the anatomy. Okay. And small intestines and large intestine, you can see that there are components of each. Sometimes they like to ask on the exam, what are some of the parts of the small intestine, some of the parts of the large intestine. So it's good to have those also written in your book. Okay, so you can see the small intestine is duodenum, jejunum, and ileum. And they consider that to be the small bowel when they are performing an EGD. those, when they're doing an EGD with the scope, that's what they're looking at, the small bowel. Okay, and you see there's 3 sections there for the small bowel: duodenum, jejunum, and ileum. Right? Sometimes the scope does not go all the way into the 3 sections, and if it does not, then you would use a modifier, and we'll talk about that as we go into further into the presentation. And there you have the large bowel or the large intestine. And you see ascending means it's going up, transverse across, descending coming down, and towards the end of that colon, you will find the sigmoid, the rectum, and then the anus. Okay. Spleen and pancreas. So we're just talking about some of the anatomy of the digestive system. And here, largest organ and largest gland of the digestive system is the liver. Very, very important. The liver serves as our filter. Okay, the liver is our filter. That's where they store glucose, okay, plasma proteins. That's how you metabolize carbohydrates. So if your filter is blocked, you're not going to metabolize the food that you take in. So it's important that we take care of our liver. And as far as I-10, you guys did really good in reference to the midterm on like coding guidelines. So I feel very confident with you doing well on the national exam with that, because it's usually the same scenarios. The coding guidelines are coding guidelines. So if you're able to maneuver through those on the midterm successfully, then you will perform the same on the national exam. Okay. So digestive system, what are the chapters as far as ICD-10? Of course, chapter 1, infectious and parasitic diseases. We also know chapter 2 is going to be for your cancers with neoplasms. Chapter 11, there actually are no coding guidelines for the digestive system. If you go to chapter 11 in your I-10, there is a chapter 11 there, but it's going to state that it's there for future use. So there have not been any coding guidelines for I-10 for the digestive system. What does that mean to you? Well, what that means, if there's no coding guidelines and you see an I-10 question, right? If you have an I-10 coding question and it's in reference to the digestive system, you know that you're not going to need to refer back to the coding guidelines, because there are none for that particular system, none for the digestive system. So you would just abstract as you read it, okay? So there's no, unless it tells you code first or something like that, but usually not for digestive system. Okay? And these are all the dental specialists for the digestive system. Like I said, it will not be covered on the CPC exam. I will let you know that first acronym that you see listed, GERD, right? Sometimes they like you to know the I-10 for GERD. Just let you know. And that stands for gastroesophageal reflux disease. Gastroesophageal reflux disease. So always make sure you know the I-10 code for that. And then for the appendix, they have inflammation of the appendix. It gives you the categories. So it's clear to see that your digestive system I-10 codes begin with the letter K. Okay? Think of something with K to remember digestive. I always say K, I'm full. Alrighty. Now, hernias. Now we're going to get into some good stuff. I want to go to the hernias. I'm going to flip around based on how the slide is, and I'll tell you what page I need you to go to. Well, that's in I-10, so I'll get to CPT in a minute in reference to that. In reference to hernias, you will be coding for hernias. Very important that you know the type of hernia, Because sometimes providers like to just state hernia. Well, we need to know, is it inguinal, femoral, umbilical, epigastric, abdominal? And then we also need to know, um, whether it's strangulated or obstructed, because that can also change your CPT code. Okay, just remember that digestive system diagnosis codes begin with the letter K. Let's get into these. These look very close. Cholelithiasis and cholecystitis, they're actually combination codes. You can have a code for cholelithiasis and cholecystitis, but there's a combination code also that describes both. So it's important that when you're reading in reference to this, to see if they're mentioning both or if it's just one, so that you can, train your mind to say, I need to look and see if there's a combination code for this particular disease. All right. So that's just a little overview of some of the anatomy and things you need to know about I-10. Now let's get into the good part. Okay. Endoscopy. This endoscopy, scopy means to view, right? So you're visualizing. Okay. So usually with the digestive system, you'll see here on the second bullet point, it says laparoscope. With the digestive system, because I'm talking CPT now, it is important in this particular chapter that you understand that there are procedures that are performed open and then laparoscopically. What does laparoscopically mean? Laparoscopically means that it's minimally invasive, right? So they're not going to cut you wide open. It's going to be a minimal incision for the procedure. Okay. And just to let you know also, in the back of your CPT, if you were to go to your index in the back and you looked for laparoscopic, you can do that. You can look for laparoscopic. It will provide you with all of the procedures that can be performed laparoscopically. Okay. It lets you know there. And if the procedure is performed laparoscopically, it will say that in the question. Okay, you're not going to have to figure it out. If it doesn't state laparoscopic, then you will code the procedure as if it was open. Okay. And I was talking about laparoscopy. So if you were looking at page 893 in the CPT, at the bottom left-hand column, that first row to the bottom, you'll see the term laparoscopy, and then it will show you all the procedures that can be performed laparoscopically. Okay, and please remember, if you have any questions as I'm going through the presentation, that you should be able to see your chat box. You should be able to see your chat box at the bottom, right above the little GoToMeeting logo at the bottom. There'll be a blank box there. You can type in to choose to send your message to everyone or to me. Okay. All right. So we were just talking here about, these are just how it's listed out, right? Starting on page 261, the different categories. And I want to go through some of the main ones for you. Let me go back one. All right, so right now I am on page 267 in the CPT, page 267. Yeah, I'm on page 267, and I am looking at CPT code 42215. 42215. Okay, so that's a palatoplasty. And what's important there for you to highlight is this is a procedure when they are going to repair a cleft palate, okay, which is a common procedures with babies, for some babies, right? So I want you to highlight that, the cleft palate. And you'll also notice that underneath the CPT code 42215 that you have an indentation, right? And the 42220 is for a secondary procedure, right? So your 42215 was your major revision. And I really like, I just want to interrupt and just say that I do like, for those that highlighted and underlined, I was able to see what you pulled out. And those people that did that got really good scores. So make sure that you're underlining from your questions to pull out the information that you're going to need to arrive at your CPT. So your 42220 is the secondary lengthening procedure, meaning they're coming back in, right? Secondary is the key word there. And 42225 is that they're attaching the flap. Okay, so it's part of that cleft palate procedure. That's what I wanted you to know on page 265. Okay. So tonsillectomy, let's do a few drills while you have your book here. So tonsillectomy, you can go to your index, right? Tonsillectomy. And I want you to find, let's see, tell me, let's see. Okay, tonsillectomy. Tell me, okay, so there is the scenario. A child that's 10 years old, and she comes in for a tonsillectomy. She's coming in for a tonsillectomy. What would my CPT code be? Okay, before you say 42820, make sure that you're looking to see if it's just a tonsillectomy by itself. I know you got the age part right, but all I'm looking for is just the tonsillectomy. Go down a little further. Perfect. So for those of you that said 42825, you are correct. And let me just mention something, because the first option we wanted to choose was 42820, right? But 42820 says tonsillectomy and adenoidectomy. So that's two things. And I'm glad that you brought that to my attention. First thing you need to know, since on the top of this page or on this section, right next to excision and destruction at the top, you need to make sure you remember the patient's age, right? Because they have to be either younger or older than 12 as far as your CPT selection. Also, if you are reading a question and it says that the person came in to have a tonsillectomy, and while the provider evaluated the patient, he also elected to remove the adenoids, right? So you have to see the two terms in order to use 42820 or 42821, right? You have to see the term tonsillectomy, and you have to see the term adenoids or adenoidectomy in order to use those two codes. Okay. On 42825, we selected that as the answer, which is correct. It says tonsillectomy primary or secondary. What does secondary mean? I want you to highlight secondary, and right on top of secondary, I want you to write the term regrowth. So what secondary means is that they could have had a tonsillectomy prior and that tissue attempted to grow back, right? So that would be secondary removal of it. Or I want you to understand that secondary also means regrowth. So you need to write regrowth right on top of secondary after you underline it, right? So again, if I'm going to ask about tonsils and adenoids, that's going to be found on page 268. And the things I'm going to ask myself is, how old is this patient? Right? They need to be either younger than 12 or older than 12. And although they're having their tonsils removed, are they only having their adenoid? Are they also or coincidentally having their adenoids removed, right? Because you have a code for just tonsil removal and just adenoid removal, which is 42830, right? So that's tonsils alone, 42825, adenoids alone, 42830. If they are both being removed during the same session, then you're going to go back up to 42820 or 42821, depending on the age. And I can guarantee they're going to ask you that question because it's one of those scenarios where there's a combination CPT, right? So they're looking to see, are you paying attention to one procedure or are you going to pick up both? Okay, so make sure you pay attention. The two key terms there, tonsillectomy, adenoidectomy, and also the secondary for the regrowth. Okay. So the esophagus, anytime you see, I'm looking under the word incision. Incision means to open, right? Esophagotomy, otomy also means to open, right? So just remember the term, the ending of the terminology term otomy means to open. It's open, incision. They're just cutting in, right? To remove, if they're removing something, then we're going to go down to the second term where you have excision listed there. So incision is just to open, excision, we're removing. Okay, so remember lesion, excision, we're removing an lesion. And then what you're going to pay attention to for lesion excision is the approach. The approach. And we were just speaking a little earlier about EGDs or endoscopies. It's important. It says endoscopies always include moderate sedation. And of course, we're going to look for indented codes and anything that's going to be in parentheses or brackets because we know that's going to give us additional information about coding for that CPT code. Okay. Okay. So remember, on the digestive system, you are going to have about 10 questions for digestive. Right now, I'm on page 270. On page 270 is where you're going to find the EGDs, or you can see endoscopy at the top of the page. Well, actually, my EGDs are 43235. Okay, so these are just endoscopies. And again, scopy means to view. So this is a little bit more terminology again. Scopy means to view. And then with the esophagus, okay, which is on page 270, these are repair codes. 43020 through 43499 are for procedures on the esophagus. And when you're coding for repairs on the esophagus, you're going to consider the approach. The approach. Let's get to some stuff I need you to know here. So I want to go back. I'm on page 270 and look at CPT code. Remember, this is how they're going into view. Let's look at CPT code 43197, which is on page 271, 43197. Okay, so it tells you It's esophagoscopy, and it tells you flexible, right? Transnasal, that means through the nasal cavity, right? And then diagnostic, so that means they're not doing anything, right? If you see the term diagnostic, they're just looking. But it also says including collection of specimens by brushing or washing when performed. And remember, whenever you see that term separate procedure that you see there at the end of CPT code 43197, where you see the term separate procedure, that means that this particular procedure is not usually performed with another procedure, right? It's performed by itself. Okay. And if it is performed with another procedure, in the chat box, please tell me what modifier we would use. In the chat box, what modifier would we use? So remember, if it's something that is not normally performed with another procedure, remember, and don't forget, you have your modifiers on the front and side cover, because I saw a few of you get the modifier question wrong, and I was like, they're in their book. Front and side cover is where you're going to find your frequently used modifiers, and a full description of all of your modifiers are going to be found in Appendix A, as in Apple. And if you look, the correct answer, separate procedure or a distinct procedural service, is going to be modifier 59. I did see quite a few of you, the majority of you, say 51. Let me just explain. 51 is when you're having multiple procedures in a particular area, right? So those, and you won't see like separate procedure next to that. If they don't have separate procedure next to the CPT code, and it's a multiple procedure in the same body system, that's when you would use modifier 51. But if you see the term separate procedure next to the CPT code, if that procedure is performed in addition to another procedure, that's when you would use modifier 59. Okay, so there's a difference between 51 and 59. 51 is for additional procedures in the same body system, right? And 59 is something, it's a distinct procedure. I'm not even in that body system, I'm somewhere else. So that's why they call it separate procedure. And when it's a separate procedure, you use modifier 59. Okay, so if it's a multiple procedure, you won't see separate procedure next to the CPT. Another important procedure that they will question you on is going to be bariatric surgery. Okay, bariatric surgery, and I'll talk about that. Bariatric surgery is usually for weight loss, but as far as CPT, with bariatric surgery, this is another surgery that can be performed either open or laparoscopic, right? So the gastric bypass or the Roux-en-Y, I believe it's CPT code 43644. 43644 is the CPT code for bariatric surgery. 43644. And that's on page 281. And this is 43644. You can see it's right under the subheading laparoscopy. So that means it's a laparoscopic procedure. Now, if it was an open procedure, if you look at the bottom of that page and it tells you, put a star next to it, where it says for open procedure, it tells you what CPT code to use. What code does it tell you to use? Enter it in the chat box, please. Perfect. Yep. So it tells you that you are to use, I'll wait for a few more people. Everyone has it right so far, but it tells you to use CPT code 43846, right? So just remember that your 43644 is for laparoscopic. Anytime in the digestive system, usually if there's a laparoscopic procedure and an open procedure, it will refer you to either one. So let's say we went to 43846. Let's turn to 43846. Yeah. 43846 is on page 284, and it tells you if you needed a laparoscopic procedure, it refers you back to 43644, right? So it's important for you to know whether it's open or laparoscopic. Also for bariatric surgery, you need to know the length of the limb. And when I say the length of the limb with 43644, it was 150 centimeters or less. Make sure you highlight that. 43644 is 150 centimeters or less. And then it tells you, the one where you just found the 43846 right above that, it tells you if the limb is greater than 150 centimeters, you are to use 43645. So for bariatric surgery, important things to know, whether it's open or laparoscopic, and also the length of the limb. Okay. And so 43644 is a Roux-en-Y surgery. Another restrictive surgery for bariatric surgery is going to be 43770. 43770, right? So there it goes, bariatric surgery again. That's on page 283. 43770 is a lap band procedure. So I put lap band actually next to it. See, it says gastric band and a port components. Okay. And as you can see, I'd actually block off those codes 43770 all the way down to 43775 because they all are dependent on the main definition of 43770. Right? So you can see there's a revision of the band with 43771, or you can remove the band 43772. So make sure you're highlighting these. And 43773 is removal and replacement. 43774 is removing the ports and the band. And 43775 is actually a different procedure that is called a gastric sleeve. That's the sleeve gastrectomy. And basically it's the fashion that they sew the stomach. Okay, so that's in reference to bariatric surgery. What else do you guys need to know in this section? Let's see. With your intestines, 4005, that's just going to be 44005. And I will be going back through some of the main things I need you to have in this chapter before we move on. Those are just the procedures on the intestines, 44005. And that would be on page 285. On 284, you can see the little image there for the gastric bypass. So again, it says for morbid obesity. So guess what? If you're going to do the CPT, some of the I-10 codes that you're going to need, the patient's either going to be obese or morbidly obese. And also you need to look and see if they have the body mass index. If they mention the body mass index, the BMI, in the scenario, you need to capture that and code it. So they may say patient had a BMI of 35. You need to make sure that you capture the BMI. But again, it will be multiple choice and the BMI will be there. Okay, so make sure you capture BMI. And BMI stands for Body Mass Index. Okay, enterostomy. Ostomy, again, is an artificial opening. Endoscopy is going to be to view the small intestine. And then you have your repairs, 44602. So these are procedures on the intestines. I'm on page 286 right now. Page 286. And as you can see at the top of page 286 on the right-hand side, I'm on the right-hand side, it says colectomy partial. Now, again, this is another procedure that can be performed open or laparoscopically. If you look at CPT code 44143, it's a colectomy. So actually your colectomy, just so you see, because it's indented, the code that I just gave you, the original description is in 44140. So you can see it's a colectomy partial, and then it has a semicolon. And if I'm looking at 44143, it's a colectomy partial with colostomy enclosure. Sometimes they'll just say Hartman procedure. So I want you to highlight Hartman procedure so that stands out with CPT 44143. And it also, right below it, tells you where you need to go if it's a laparoscopic procedure. So main thing, digestive system, is the procedure open or is it laparoscopic? Is it open or is it laparoscopic? And they will use terms like low pelvic anastomosis, which is like in CPT code 44145. So make sure you're looking for the terms that they're mentioning in the scenario in the description of the CPT, the definition of the CPT. 44900, let's turn there for a second. 44900. And that's on page 292. And this is in reference to the appendix. So I can tell you, you're going to get a question on the appendix too, or also, right? On page 292, where it says appendix, I actually wrote open there because this, again, when it's digestive, you need to know if it's being performed open or laparoscopically. Once you just see incision, or I'm sorry, excision, appendectomy, I want you to write open next to it. All right. Look, something else I want to bring to your attention. On the top of page 293, appendectomy is a common procedure, right? And it also can be performed with other procedures. If it is performed by itself, you will use 44950. If the appendectomy is performed in conjunction with another procedure being done at the same time, then you see that's an add-on code, 44955, right? So that's when it's done at the time of other major procedure, not as a separate procedure, because if it was a separate procedure, you would just use your 44950, right? But if it's done in conjunction with another procedure, you would use 44955. So for you to remember, you might want to put more than one procedure or make sure you highlight that term in the definition. Okay, you want to highlight where it says done at time of other procedure. Okay? And so those were the open codes for the appendix or the appendectomies. And then you can see right under laparoscopy, I'm still on page 293, that there's a laparoscopic CPT code. And it does say laparoscopy, right? And sometimes in your, another way for you to know, I just wanted to clarify, I just see a question in the chat box. Do we use both codes if there are two procedures? Well, if there are two procedures, you would only be using the 44955. You would only use the 44955 if it's done in conjunction. If all that's being done is just the appendectomy, being the then you would use the 44950. That's when you would use the 44950. No problem. Okay, and then we can see the two codes for the laparoscopic version. Okay, so moving on to procedures of the rectum. So you can see there, simple ones. Provider I know calls it the lumps and bumps. Well, that's drainage of the abscess. So you have to incise that abscess to drain the fluid, right? Incision. Excision means you're removing it. Proctectomy, see? Partial or complete, you need to know. And where it has endoscopy and it has proctosigmoidoscopy, sigmoidoscopy, colonoscopy, I just saw those. If you look on page 289, they have the definitions there for those terms. Okay. And I actually wrote G0105, which is a HCPCS code, next to sigmoidoscopy. If it's a Medicare patient, that's what you would use. I'm on page 289. I just wanted you to see the definitions there for the terms that we have, the definitions. And next to sigmoidoscopy, I wrote G0105 if the patient is Medicare. G0105. All right, so back to procedures on the anus. 46020. Also on page 294, it's there. Page 294, the definitions are there. And it has the image of the rectum up on top with the tumor. Yummy. All right, so underneath that, you can see the destruction of the tumor 45190. That's for the destruction of a rectal tumor. And so it gives you all the different approaches to destroy the tumor. And this is a transanal approach, right? Through the anus. That's how they're going to destroy the tumors. So look, there's a difference now. I just want to bring something else to your attention. This is destruction, right? That means they're using some type of device to destroy the tumor, be it the laser, ablation, or cryosurgery, which means freezing it, right? But if you look down, right underneath it, it says for excision. That means they're just cutting it. They're not using a device to destroy it. They're doing it by another method. Excision. The term excision is going to change everything. There's a difference between destruction and excision. Okay. Yes, your HCPCS code. I had someone ask here, do we use HCPCS codes? Anytime you see the term Medicare, now unless they ask you, for the HCPCS codes, because you will have, there's only five questions on the exam in reference to HCPCS. But if you're reading a scenario and it says the patient is Medicare, sometimes they'll even put the Medicare in bold. Anytime you see Medicare and they're emphasizing Medicare patient, your answer is going to be a HCPCS code answer, right? And Medicare HCPCS codes begin with the letter G as in good. Okay. All right. And someone was asking me the code. I said G0105 was the code. That's the G code for Medicare for a colonoscopy, sigmoidoscopy. That's when um, they're examining the entire colon, including the rectum and some of the descending colon. All right, so back to that. So I'm back on 294. And again, I just want to reiterate the difference between destruction and excision. Anytime you see the term excision, that is your root I'm calling it a root operation, but that is the main aim of the surgery. And destruction means they're using a device to kind of devour or get rid of that tumor. So there's a difference between destruction and excision. And even with this scenario here, it refers you to see other CPT codes. So you need to know the difference when you're reading. Okay. All right. That's for the liver. I'm into the 4/7. And then they have a colonoscopy. That's new. I haven't seen that in the book before on 295. Okay. It even tells you there's a decision tree because colonoscopy are very common procedures. Okay. And you can see it's been divided. I'm looking at the decision tree on 295. So you can see there's a diagnostic side and then there's a therapeutic side, right? So therapeutic means they're actually treating and diagnostic means they're looking. Okay. And then your 4/9. On page 296, just got one more thing to let you know. This is in reference to the colonoscopy because like I said, it's a very common procedure. And I am very confident they're going to ask you a question about colonoscopies and how to code for them. On page 296, they provide a coding tip for coding for colonoscopies, right? It even tells you colonoscopy is the examination of the entire colon from the rectum to the cecum and may include the examination of the terminal ileum or small intestines. What's important to me though, the part I want you to grab from this little blurb here is towards the bottom. It talks about a modifier. If the physician, this is what's important. I need you to highlight this because you're going to see it again. If the physician is unable to advance the colonoscope to the cecum or the small intestine, right? Remember there was 3 parts of that small intestine. If he is unable to place the scope and let it reach the small intestine, and it will say the provider had difficulty reaching the small intestine, something like that. You need to report the code for your colonoscopy, 45378, or if they say it's through a stoma, 44388, with modifier 53. Trust me, you're going to see it like 2 times. You need to know the modifier, which is 53 on this one, right? Let me go over it again. If the physician is unable to advance the scope either to the cecum or the small intestine, then you're going to take your colonoscopy code, which is your 45378 or your 44388, depending on whether or not a stoma, it's being done through a stoma. You would then append modifier 53. Modifier 53. Okay. I'm saying it like 3 times because I know someone's going to forget, and I know they're going to ask you about it, right? And so I put on page 297 next to CPT code 45378. You got to remember to put modifier 53 if they are not able to view what? The cecum or the small intestine, right? So I kind of highlighted or drew a highlighted box around that actual tip, that coding tip there, modifier 53. Colonoscopies, if it's not able to see everything, modifier 53. And then they move on to talk about hernias. Okay. Hernias are important. I was saying that a little earlier. And hemorrhoids. I want to talk about hemorrhoids first. The hemorrhoids are going to be found on page 300 because I know they're going to ask you a question about hemorrhoids. I think I've given you about 10 tips. And I will give you the need to knows. I'll send that out to you. I'll send out the 10 need to knows for this particular section. And just make sure we've discussed them already, but just make sure you understand them. All right, so on page 300, this is where we're going to find our codes for hemorrhoids. You see there's a diagram on page 300 or illustration, because sometimes they're going to ask you how many columns or groups, and that will be listed in your scenario. So a column is basically an internal hemorrhoid. That's what a column is. And usually they, again, the hemorrhoid is inside. Okay. If you look at CPT code 46250, you can see it's a hemorrhoidectomy, external. So the hemorrhoids are external. Put a box around external, and then it has 2 or more column groups. So that's what you're looking for. So when it's time to code for your hemorrhoids, I got hemorrhoids written right in the middle next to the little diagram, HEM, it's right there, ORRHOID. When I'm coding for my hemorrhoids, I need to know if it's internal or external. And then I need to know how many columns or groups. How many columns or groups? So if I stated or asked, I'm just going to give you a little scenario so you can get your chat box and your fingers ready. Right. Patient comes in, 24-year-old male, has both internal and external hemorrhoids and 4 groups. In the chat box, please tell me what CPT code that would be. I was just looking at code 46250 as an example, but now my scenario now is patient has internal and external hemorrhoids, and they have 4 column or groups. 4. Internal and external. So if you don't have internal and external highlighted, you might give me the wrong answer. Alrighty, I see some people have corrected that now. Yes, the correct answer would be 46260. As you can see there, it says internal and external, and it says 2 or more column groups. So very good. So that's what you're looking for, right? And you should have wrote those steps down to remember what to look for. Because some of you chose 46255 or 46250, but the 46250 was external only, and I said internal and external, and the 46255 said single group, and I said there was 4. All right, so just make sure you pay attention to how many columns or groups and whether the hemorrhoids are internal or external. So it's important to highlight those keywords in those CPT codes so you can move through that one pretty quickly. Now, the last thing I want to cover in this section, digestive system, is going to be, did I do the cholecystectomies? The cholecystectomy is on I'm on page 307. I'm on page 307. Okay. So again, with the digestive system, remember you got to ask yourself, is this open or is it laparoscopic? So you can see on page 307, these are all cholecystectomy procedures. You can see the laparoscopic side, 47562, right, for cholecystectomy. And if it's open, you're going to go on the excision side, 47600, open. So sometimes they'll say an incision was made. They won't say it was an open procedure, but if an incision is made, and they'll say the size of the incision, it's going to be an open procedure. They'll also say incision with the laparoscopic, and they may not say laparoscopic. Another term for you to, or a little tip for you to know it's a laparoscopic procedure is the term trocars, TROCAR, which is an instrument that they use during laparoscopic surgeries or laparoscopic procedures, trocars. Okay, so just make sure you have that. So that's a keyword to help you with laparoscopic trocars. And usually when it's open, they'll just say incision. An excision is because that category, they're removing gallbladder. All right, so now I can do my hernias. All right, hernias are found starting on page 314. So right now I'm on page 314. Page 314. Right? And as you can see, it says repair. On top of page, okay, so 314, I'm looking at CPT code 49495. I'm just randomly picking one, 49495. These are hernias repairs on infants. Okay, so the 49495, make sure you highlight where it says younger than 6 months. Younger than 6 months. And also make sure you highlight where it says repair initial and it tells you the type of hernia. That's an inguinal hernia. Inguinal hernia, younger than 6 months. And then your 49496 is whether that hernia has some type of obstruction. If there's any type of obstruction or something blocking, you will use the term incarcerated or strangulated. It now becomes incarcerated or strangulated. Okay, so when you are coding for hernia repairs, you need to know what type. Okay, it's up here on the slide, the type of hernia, whether it's strangulated or incarcerated, and then whether it's initial or a subsequent repair. I would also say age. They don't have that there, but I would say age if we're talking about an open hernia repair, which these codes on page 314 and 315, these are open hernia repair codes. These are open hernia repair codes. So you see 49500, that's an inguinal hernia. Yeah, you're looking at the age there. 49520 is a reducible hernia, and it tells you that's any age. Okay, and then there again, you have their incarcerated or strangulated right underneath it. So there's different types, right? 49525, it says sliding. 49540, lumbar. 49555, femoral. So pay attention to the type or the name of the hernia, whether there's any obstruction, because if there is, when you choose the incarcerated or strangulated, that's going to give the provider additional reimbursement because it's a little bit more difficult to treat, right? It's a little bit more difficult in reference to that procedure. One last thing on the open side that I want to mention, on page 315, at the top where it says 49568. 49568. That is the mesh. You see it's an add-on code, and sometimes when they're doing a hernia repair, they will use mesh. So make sure you write mesh right under 49568. What's also very important for you to know about this CPT code, the 49568, are the codes that it can be used with, because I know we're looking at open hernia repair codes on page 314 and 315, but really the 49568 can only be used with 4 codes on this page. And it tells you right underneath. Use 49568 in conjunction with 11004 through 11008, which is coming from integumentary, right? Or 49560 through 49566. So what I want you to do on page 315 is to draw a line from 49560 all the way to 49566. And on the outside of that line, you're going to put a plus sign and then your 49568. So you know these are the only codes that you can use the 49568 with. 49568. Okay, very important. All right. Turn the page for me, page 316. On page 316. All right. On page 316, you can see these are the laparoscopic hernia. The difference with laparoscopic hernias is if mesh is used, it's already included in the CPT. With the open, you had to use the add-on code, right? But if mesh is used in the laparoscopic hernia repairs, it's already included. Okay, let's see. Okay, CPT code 49562. I'm sorry, 49652. It says laparoscopy, surgical repair. It tells you the types of hernia. It could be a ventral, umbilical, epigastric, and then in parentheses it says includes mesh insertion when performed, right? So as you can see, the mesh is included in the CPT code already for the laparoscopic procedures. Okay? And then they still have the incarcerated or strangulated. Okay? So just remember with the laparoscopic, the mesh is included. With the open, you will only use 49568 with the codes mentioned, 49560 through 49566. Okay. Did that make it clear, or do I need to repeat that? Just remember the open codes, the open hernia codes, if they're using mesh, if they're going to use mesh and the hernia repair is open, it can only, the 49568, which is the mesh code, can only be used with 49560 through 49566. And we drew that line already, and we wrote 49568, right, on the ones that can be used. And with laparoscopic hernia repairs, which are located on page 316, the mesh is already included. The mesh is already included. Don't forget, you're going to have a couple questions about hernias, maybe 2 or 3, and that's going to wrap up your 10. Let me see what I had. See type of things you're going to need to know. Yep, so hernias. And I'm going to send this out to you guys. I'm just looking at my need to knows to make sure I covered them. Your tonsillectomies, remember if there's a combination code, and when I say combination codes, automatically in your head you should be saying, okay, well, she's talking about whether they have a tonsillectomy with an adenoidectomy, right? Also, your hernias, which we just just discussed. We need to know whether it's open or laparoscopic, the age of the patient, the approach that they're taking, and whether it's incarcerated or strangulated. And we spoke about the EGDs. The EGDs, like if they're not able to advance the scope into the cecum or into the small bowel, what modifier are we going to use? That's going to be modifier 53. We spoke about colonoscopies, which can be found on page 296. And remember, if it's a Medicare patient, then you're going to use a HCPCS code, which begins with G. We spoke about bariatric surgery. And when you're coding for bariatric surgery, you need to have that diagnosis of morbid obesity. You also need to have the BMI, right? BMI is the body mass index. You also need to know the length of the limb, whether it's over or under 150 centimeters. Okay. And then the approach, whether that's laparoscopic or open for that actual procedure, right? And if you get lost, it will always tell you where to go for the opposite approach. Okay. Gastrostomy is another procedure. That's when they're placing the tube, like a feeding tube placement. I just want you to write down CPT code 43246. 43246. That's for the tube placement. Right? And then we spoke about hemorrhoids, right? Need to know if they're internal or external and how many columns or groups. And then we spoke about appendectomies, knowing whether they're performed open or laparoscopically. And the last thing I have here that I didn't cover was on page 304, and that is the liver tumors. Liver tumors. And basically, the liver tumors is going to be the same as far as how they are going to be destroyed. I said 304. How they're going to be destroyed, liver tumors, right? So if I'm looking, I'm on page 304, and I'm looking at CPT code 47382. And you can see it's ablation, right? It doesn't say excision, it's ablation. And then you want to know how it's being destroyed, then you can see it says radiofrequency, percutaneous radiofrequency. And the ablation is for one or more liver tumors. And for 47383, the method is cryoablation. So again, it's just about the method of destruction on those, on what you're going to pay attention to. So make sure you highlight radiofrequency under CPT code 47382 and cryoablation CPT code 47383. Okay, did that, and did that. And that was the last thing I wanted to focus on for the digestive system. So I'm going to open up the line to see if anyone has any questions before I move to the next one. So just give me a sec. Does anyone have any questions for me? You are free to talk while I get the next one. Just wanted to show you this for the 43246 is for the feeding tube placement. 43246. Yeah, that's the gastrostomy tube, which is a feeding tube. And as you can see, I'm showing my screen again, so I can give you those HCPCS code ranges for colorectal screening. One more thing I want to talk about with HCPCS and Medicare, right? If a patient has a family history of, like a sibling, let's say they're coming in for this colonoscopy and they have a family history of like colon cancer, right? Either a grandmother, sister, sibling, that patient now becomes high risk, right? So just remember, if the patient has a family member that has had the disease that they're coming in to get screened for, then now that patient becomes high risk. They become high risk. Okay, just wanted to make sure. So any other questions before I switch? No? Alrighty, so I'm gonna keep moving right along and I'll just switch this one out. So the next one coming up is going to be male urinary and female. And I'm going to do all of those and then we'll stop. The male is really, really short, so just like a page. The female one is where I need to get to make sure we get all of the information covered. Urinary male. Beauty and so please let me know in the chat box. Page. I see someone wrote page in the chat box, but I'm not sure for what. So if you can just clarify where it has page, unless you got it already. Oh, the feeding tube. 43246. 43246, page 275. 275. So now we're moving on to the male and urinary. And let me tell you about this section. Urinary, male, I don't have female up here. That's a separate presentation by itself. But all three, right, begin with fives, right? So that's going to mean that they're only going to pick 10 questions for these three systems combined, right? So you have urinary, which starts with your 500, and then you have the male, which is then goes on to what page? The male urinary system is pretty short, and so is the male. The male starts on page 339, and that only goes to 346, so that's not even 10 pages. And then we go into female. So let's get started with that. So again, like I was saying, in these three sections, you're only going to have 10 questions. And there's quite a bit of information between all these chapters, so I'm going to wind it down, narrow it down for the need to knows. On page 318, there's really nowhere to write, but on 318 is maybe where you can put your need to knows for all three sections, right? Because you want them grouped together, right? And as far as the things you're going to need to know, we'll talk about those. But for urinary, it's going to have things to do with renal, bladder tumors, cystourethroskopies. We'll talk about that. Bladder tumors, like I said. For the male, we'll talk about penile prosthesis. Definitely going to be a question on circumcisions. And the male section is so short that maybe will be all they'll ask. And then on the female, most definitely deliveries, right? Deliveries, hysterectomies, and in vitro fertilization are what we're going to be talking about, right? So right now I am on page 319. Okay. They went straight to the male. So we're going to flip back and forth a little bit. Looks like how they have this set up. Well, I'm going to leave that up there, but I want to go through this. Page 318, I'm sorry, page 319, where it says kidney, I want you to write renal pelvis, Okay, so remember renal abscess, because they're going to talk about a renal abscess of the kidney. Just remember renal is pertaining to the kidney. Okay. 50010 is in reference to exploration, and 50020 is the drainage of an abscess, and it tells you that it's open, is the approach. The approach is open. So there you have. For the kidney, they only give you two things for incision, right? You're going to go in and explore just to look, or you can drain your abscess with the CPT code 50020, and that approach is open. All right. What else do I need to know for urinary? I am on page 323. Page 323. Sometimes they'll talk about nephro kidney. The suture of the kidney, I want you to put a star next to CPT code 50500. Nephrorrhaphy, that's to suture, okay, the kidney. So that's maybe someone that had some type of, it could be that they were having surgery and the provider accidentally punctured the kidney. That happens sometimes. So either wound or injury, that's your 50500 to suture the kidney. And as you can see here, they have a few procedures that are performed laparoscopically in this section also. Where else do I want to go with this on what they're going to cover? I'm on page 329. And 329 are for procedures on the bladder. Okay. So as again, incision means you're just going in or you're cutting into. That's why you have the term otomy. It's going to be the same for all the body systems. These incisions, removals, excisions, same procedures, different body parts. So you have to look at the terminology. The ending of the terminology is going to give you a suggestion on what's happening with that procedure. Right? So 51045 is an insertion of the catheter or stent. Look, it says separate procedure. So that means it's not usually done with something else, right? And if it says separate procedure in the chat box, please tell me what modifier. Modifier 59 if it's separate procedure. Okay. Remember, 53 is like if they were trying to look at, remember, if they're not able to reach the cecum or the small bowel, then you would use 53. All right. I see you guys caught yourselves there. Don't get confused with 53 and 59. Okay. And then moving on down on the, you'll see removal. What are some of the procedures in reference to removal from the bladder? You can aspirate, right? And that's telling you by what method. That's by needle. Look, 51101 says by trocar, right? Or 51102 is like, we're going to aspirate and we're going to insert a suprapubic catheter. So the first two we're just removing, and the 51102, they're going to aspirate and then place the catheter. And under your excision category would be removing like a cyst, and it says with or without umbilical hernia umbilical hernia repair. You can see that kind of the body systems kind of run into each other as we're working our way through the body. Let's see, bladder that was the bladder repairs. And as far as bladder tumors, cystourethroskopies also. Page 332 is where I want you to be right now. Page 332. So on page 332, you'll see these are cystourethroskopies. Cystourethroskopy. If I'm looking at, I'm just looking at a code right now. I'm looking at CPT code 52000. 52000. Again, I see that separate procedure in parentheses. What does that mean in the chat box? What modifier? Perfect. Everybody has it now. This is great. At least I know you know when to use it. Right? So, cystourethroskopy. Well, it says separate procedure. Anyway, I just want you to know cystourethroskopy is they're just viewing the urinary bladder. Remember, scopy is the view, and they use a cystoscope to do that. Okay, so and as far as the urethra, because we'll be talking about the urethra since we're talking about the urinary, and it's a tube that carries the urine from the bladder to the outside of the body. And the scope that they use is kind of like a microscope, and the lens that they have on the microscope or the telescope, the physician can use it to focus on the inner surfaces of the urinary tract when he's viewing that. And some of the scopes that they use have these optic fibers, and they're able to transmit the image, so that the provider can see it clearly, just so you have an idea of what a cystoscope is. Right? And we already know what separate procedure is. And then on page 333, at the top of the page, I want you to write, remember the size of the tumor. Okay, so we're talking about tumors in the urethra or the bladder. For example, CPT code 52234, right? So they're going to do a cystourethroskopy, and then they're going to do some cryosurgery, right? So they're maybe getting rid of some of the tumors in the bladder, but the size of the bladder tumor is small, right? You see that? 0.5 up to 2.0 is considered small. So you want to make sure you highlight the size and then highlight the category. Like I have small highlighted and then the size, and then I have medium highlighted and then 2.0 to 5.0, and then large is anything over 5 centimeters. Yeah, so large is anything over 5 centimeters for the tumor. So remember, when you're coding for cystourethroskopies and they're destroying a tumor in the bladder, you need to know the size so you know which CPT to pick up here. Right? I am on page 334. Page 334. Okay, on page 334, look at CPT code 52332. 52332. Okay, on 52332. Again, you can see this whole page is we're still talking about cystourethroskopies, right? And because they can go in and do other things. For example, the 52332, they're going to do the scope, but they're also going to go inside and insert a stent, a urethral stent. Okay, and sometimes they'll just call it a double J stent. I like to write double J right outside of that CPT code, double J type, because that's what they like to say in that section. What's also important right underneath it, the 52332, it tells you do not put a star there. Do not report 52332 in conjunction with what? It tells you 52000 and 52353. Okay? When performed together, where? On the same side. So that's going to be important on reading on where to insert. So again, I'm on page 334, and I am talking about CPT code 52332. 52332 is talking about a stent, and usually the stent is called a double J type. That's the one they usually discuss in the scenarios. And what's also important is what's listed right underneath it, where it tells you do not report 52332 in conjunction with 52000, 52353, 52356 when performed together on the same side. So if it's different sides, rule doesn't apply, right? Right now we're talking about if it's performed together on the same side. You do not use those. Okay, on page 335, put a star next to CPT code 52356. That code there is just, the little symbol there is just telling you it's out of numerical order. Why they do that, not sure. But that's out of numerical order. But you see, this is also a cystourethropy. Right? But they're breaking up stones. The term lithotripsy means crushing of the stone. So they may have a stone there. Lithotripsy means breaking up stones. And it also is including the stent. Remember the insertion of that stent from that CPT code 52332? But the only difference is, in addition, they're breaking up some type of, they're doing a lithotripsy, crushing the stones. Okay. And again, under 52356, they have an important note. So a lot of these, you're going to have to make sure you read underneath the CPT code to know whether two codes or not can be billed together on the for the urinary side. And I think that's all I had for urinary. I just want to make sure. Yep, that's all I had for the urinary system. I'm going to open the line. If anyone has any questions, we'll move right in to the male reproductive. Does anyone have any questions? The line is open. No questions. Everyone's getting this. Okay. Sure? Speak now. All righty. Too easy, I guess. We'll see. All right. So I am moving on to the male reproductive system, which starts on page 339. Not very long at all. Only goes to page 346. Right? On page 339, you can see that this is in reference to the male genital system. So it has been broken down to the various portions or components of the genital system, starting from the penis, ending at the prostate on page 340. So again, when you're reading your question in reference to the male, you got to highlight what body part are they talking about. That's the first thing you need to know. Right? What body part? And again, with each of the chapters, if you're looking at page 339 along with me, you can see the different approaches that are taken for that particular body part. For the penis, for example, they have an incision, destruction, excision, introduction could be a penile implant or a catheter, repair could be orchiopexy. Orchiopexy are testicles that have not, well, that would be in the testes, but testicles that have not descended. They could be up in the stomach somewhere. There's a surgery for that, right? Then they have procedures on the testes, the scrotum. So you're looking for the part of the male genital system the procedure is going to be performed on. That's the first thing you want to highlight in your scenario. Now, once you've identified what part they're going to perform the surgery on, then you're like, okay, what are they getting ready to do to that part? Take something out, put something in, so then you'll know, look at the page, what page you need to go to. First of all, if it's anything to do with the penis, it's either going to be on 341 through 343, right? Testes, once you see the word testes in your scenario, your answer is coming from page 343. There's no other place to go, right? So you see what I'm saying? Look for the body part. You're going to look for the body part, and then you're looking to see what they're doing to that body part. Okay. Here they have a couple of things which I know they're going to talk about, so they are important. And again, I will be sending this presentation to you or the PowerPoints to you so you can take your time and go through the slides. Important to know, the penile implants, there's different types. So when you're reading a question about penile implants, you have to make note to self, is this inflatable, non-inflatable, and what are they getting ready to do with the implant? Remove it, insert it, very important to know, right? And then circumcisions, we're going to talk about that. It's based on age, and that should say whether a block is included or not, right? So on page 340, you can also see an illustration of that area because sometimes you never know. I don't want you to get lost or confused when it's time for anatomy. Remember about the resources and the illustrations that are available to us. We have some in our CPT and we also have some in our I-10, right? So I'm on page 341. It's where I want to start. Why do they have urinary? Well, we already got these two, cystourethropy. It says know the difference between ureters and urethra. Okay, well, you know the ureters are the tubes that the urine travels through, and the urethra is going to be the outlet. And we already know about the bladder tumor code size, right? And so if they have, code is based on the largest size. So that will be already illustrated for you in your scenario. You don't have to worry about that. Okay, let's get in here. We already did urinary. I want to get to the male. Okay, so male genitals is going to start with the letter N. N. Okay, and here's a few acronyms. Benign prostatic hypertrophy. I believe that's what that acronym stands for. And what that is enlargement of the prostate. Prostatitis, same thing. And the PSA is a prostate-specific antigen. Okay, those are just some terms. Make sure that you are also reading the corresponding chapters. Remember, you do have your PMCC textbooks, which will further describe the conditions that are listed here. Okay. So there's some of the common diseases. I just want to get to the, this is urinary. I did that already. I want to get through to the male. All right. So again, I'm not going to go through each one of these that's listed on the slide because these are broken into the categories on page 339 and 340. Actually, where do I want to get to? I want to start in my book because they're not doing it the way I want you to know it. All right, on page 341, where I want to start with is going to be the circumcisions, and that is CPT code 54150. Okay. What's important about this particular code is here on 54150, it says circumcision using a clamp or other device with regional dorsal penile or ring block, right? So I want you to highlight where it says dorsal penile or ring block. So that's included in your 54150. Now, jump down to your second set of parentheses, put a star and an arrow, maybe two arrows, because they're going to ask you this question. May not be a question, but you're going to have to use your coding concepts to understand how to answer it. All right, so your 54150, remember, included the dorsal penile or ring block. Then you jump down, and then it tells you report 54150 with, I love when it tells me stuff about modifiers, because that's going to make it easier for you to answer your question. With modifier what? 52 when performed without dorsal penile or ring block. See, this is what trips everybody up in this. And I don't know why, because it's written right here. We just forget to read, right? So modifier, if there's, and you'll read the question, if they do a circumcision and it says they did not utilize a dorsal penile or either or ring block, then you would append modifier 52. Very important. I guarantee you 100%, I'm not going to say dollars, 100% that you're going to see that question, or it's that in some form or fashion. Because again, this chapter isn't that big, and circumcisions, when you think of males, is going to be a very, very common procedure. Remember, 54150, the dorsal penile or ring block is also included in the procedure. If it is not, if it states that they did not use or elected not to use a dorsal penile or a ring block, you will append modifier 52. Right? I'm on page 342. On page 342, at the top of the page, this is where you're going to write penile prosthesis, right? Penile prosthesis, and I'm going to go through a couple of the codes here, some of the things I want you to highlight on page 342, starting with CPT code 54406. Get your highlighters ready. 54406. All right. CPT code 54406, you're going to highlight removal of all components. Right? Removal of all components without replacement. Right? They're not putting them back, they're removing everything. 54408, make sure you're highlighting where it says repair. They're just coming in to repair. So these are keywords. So now I know the body part is the penis, right? And then somewhere in that scenario, once they say penis, I'm looking at my reference page and I'm like, okay, if they're going to talk about the penis, then my answer is going to be coming either from 341 through 342. But now that I said prosthesis, then you know it's going to be on page 342. You're going to see the term penis, prosthesis. This is the page where you need to be. Once you've identified those two things, now you're like, what are they getting ready to do with the prosthesis, right? So we already got 54406. They're removing, they're taking everything out. 54408, they're doing a repair. 54410, they're going to remove it, maybe an old one, and replace it with a new one. Right? And this one says at the same operative session, so make sure you get that. It's happening at the same time. And let's see, what is the difference between 54410 and 54411? Because both of them say removal and replacement of all components. But this one states, which is important, this is the part I want you to highlight also, through an infected field. Through an infected field. And then we go on down to 54415, and that's removal of a non-inflatable. I love it when they give you more terms because that makes your selection more solid. It's telling you the type, a non-inflatable or inflatable self-contained penile prosthesis without replacement, okay, of prosthesis. And then 54417, put a star next to that. That's a common one. Removal and replacement of non-inflatable penile prosthesis through an infected field at the same session, operative session, including irrigation, they're going to wash it out, and debridement, scrape off anything of that infected tissue. Get rid of that. That's your 54417. So it's doing everything, right? Removing and replacing, but it's also irrigating and performing a little debridement, which is cleaning the infected tissue, getting that out of the way. Very important, penile prosthesis. Okay. Okay, and for the testes, anything I need you guys to know? Testes. I'm on page 343. CPT code 54550 under exploration. Okay, remember I told you the testes, they have a condition called orchiopexy. And that's when the testes do not descend, they don't come down. Okay. These two codes are just to explore, just to look, and it tells you exploration for undescended testes, and it tells you where it could be, where they could be. They could be in the inguinal or scrotal area, and it tells you for bilateral procedures, if something's bilateral, you will append, a bilateral meaning on both sides, modifier 50. Modifier 50. And that orchiopexy, what I was talking about, the actual procedure, the up top, we were just looking at the exploration. But if you go down to the repair CPT code 54650. Right. All right, so someone just checking the chat box, the difference between 54117 and 54111. They're basically the same. It's just with 54417, it's a little bit more extensive. They're also going to irrigate the area and do a debridement. Remember, debridement is a procedure by itself in the integumentary system, but they've rolled that up into this CPT code when they're removing and replacing the inflatable penile prosthesis. So that's the difference. All right. And 54650, like I was stating on page 343, the orchiopexy is basically how they're going to go in to descend those testicles. 54650, they're going to go through the abdominal. That's the abdominal approach. Right. Go one up, 54640, that's the inguinal approach. Sometimes they'll have a hernia repair, so that's why this code says without hernia repair. If a hernia repair is, look, this is great. I just love talking about this stuff. If a hernia repair is performed in addition to the orchiopexy, it tells you for inguinal hernia repair performed in conjunction with the orchiopexy, it tells you what code. So you would add on your hernia code, right? From the code range 49495 to 49525. Okay, I'm sorry, not 54117, it's 54417. 54417. for the person that asked in the chat box. I think that's it on the male side, actually. We talked about circumcisions. Let me just go back to my need to know. Yeah, the suture of the kidney, cystourethropy, penile prosthesis, circumcision, bladder tumors, and then your renal tumors. Okay, so what's left is the female. I'm going to open up the line. That was in reference to male, was pretty fast and quick. The last thing that was introduced not too long ago, if you look on page 347, page 347 are going to be the intersex surgery, and that's male to female, female to male. So there are CPT codes for that. And yes, some insurance companies do cover it. All right, that's the last one. So I'm opening up the line. Does anyone have any questions in reference to the male that you needed me to clarify before we move on? No. All right, so let me just change this out. And we're going to wrap up with the female. All right, so everyone should have the female genital system up on the screen now. Not too long either. This should keep us right on time. All right, I'm going to take my time here though, which I did with the others, but female, what's going to be important are things like pregnancy, and you can see on page 348, there's a nice blank page there for you. And also on page 347, maybe that's where you want to write your 50,000 need to knows, because that's a little bit more space towards the end. There, you can write them on page 347 or 348 for the 50,000 category. Now with female, you know, I already told you what the big things are going to be: pregnancies, hysterectomies, and yeah, deliveries. We'll talk about that. And that's it, because then you go into endocrine. All right. So female reproductive, right? So on page 349 is where you're going to find a illustration of the female genital system. I just keep bringing that to your attention because sometimes with the anatomy, they like to ask us questions and we need to have a reference if I'm not able to talk to you during testing time. Remember, you have illustrations in your CPT as well as your I-10, which I have repeated numerously. Okay. All right. And delivery. And then we'll talk about delivery and twin delivery and hysterectomy. So let's get into that. So I want you to pay attention, though, to the reference pages. Here we go again. Female genital system has been broken down in your reference pages by the elements that make up the genital system: vulva, vagina, cervix. Turn the page. You got your ovaries, in vitro fertilization. Trust me, you're going to have a question on that. Remember, page 360 is where it can be found. And then you see a big portion of that is maternity care and delivery, which is usually the biggest thing with the female reproductive. And then it goes into endocrine, which is, I don't know why they have endocrine on their female system, because that's for everybody. So I'm going to say it stops at maternity, right? All right. I am right now on page 351. 351. Now, please note that on page 351 at the top, under female genital system, that green heading, it gives you quite a few parenthetical notes and refers you to go somewhere else. Right? But you won't use these, but I just want you to know that they're there. And it also provides some definitions. Vulvectomy, that means removing some of the vulva. And then it gives you the definitions of simple, radical, partial, and complete. Okay. But I'm moving down right now on page 351 under the destruction category. On top of CPT code 56501, that's an important code, it's a destruction code, right? And it has vulva there. Do you see that? It says vulva simple. I want you to know that the vulva is not just the vulva. It has other parts that make up the vulva. So on top of CPT code 56501, I want you to write the labia mons pubis. I'm going to type it in the chat box because I know everybody's like, what? The labia mons pubis is also part of the vulva. The labia mons pubis. Does everybody see that there? Chat box. It's in the chat box. So that's also part of the vulva. Okay, so they're talking about destroying lesions in that area. Okay, so sometimes they may just say that the lesions were destroyed on the labia mons pubis, or the labia and the mons pubis. You need to know, okay, well, that's part of the vulva. That's where I want you to go with that, to make sure you understand that that's part of the vulva, the labia, which are the lips, and the mons pubis, which is right on top. It's your mons pubis area. And then the destruction of the lesions, there's two categories. Well, you have to know the method, because remember, when you see the term destruction, they're talking about a method of destruction, not just an excision. And 56515 is extensive, and they will use the term extensive. Okay, that's what I want you to know on page 351. Let's see where else we need to go. I want to talk about the hysterectomies. So if you could please turn to page 356. Page 356. 356. Okay. Now, these are different types of hysterectomy procedures. And sometimes, based on how they present the scenario, they expect you to know the various acronyms like TAH, or that stands for total abdominal hysterectomy, right? So next to CPT code 58150, I'm on page 356. I'm looking at CPT code 58150. I want you to write TAH. TAH, total abdominal hysterectomy. right? And when it's a total abdominal hysterectomy, they're removing the cervix and the fundus. So cervix and fundus. All right, that's a total. When it's a partial hysterectomy, if they say if the patient had a partial hysterectomy, the cervix remains. Remember, with the total, the cervix is removed. With a partial, the cervix remains. Right. And also CPT code 58180, where it says subtotal in that parentheses, that indicates partial. So I want you to write partial next to 58180. Okay. 58200 is TAH. That means total. This is the way they're removing the uterus, right? They're removing it through the abdomen. And then 58200 is saying, yeah, we're going to remove the uterus, and also we're going to take part of the vagina. Boy, 58200. Right? That's a total. That's another TAH. Remember when I said the term radical? When you see radical, what else is being removed? In the chat box, please. What else is being removed when I use the term, or when you see the term radical? Anybody remember? Okay. So when they say radical, always remember that means lymph nodes are involved. Okay. Whenever it says radical, lymph nodes. So I actually just wrote lymph nodes already. It's already in the description of 58210, but I need it to jump right out at me. So I'm going to write it next to the CPT code. This is fun. We're getting all the notes in our books. We're getting them all pretty and getting them decorated. The 58240 has to do when there's cancer involved, right? So it says malignancy there. So they got to get rid of everything at that particular point. Cancer has reached the site. So cancer is involved in that CPT code because they're removing it because of the malignancy. All right, removing it because of the malignancy. Another thing with the hysterectomy, knowing the approach, right? We need to know the approach, whether it's coming through, because sometimes they have a TVH, which is a total vaginal hysterectomy, which is your 58260. That's TVH, total vaginal hysterectomy, is the weight of the uterus. We need to know, or it's important to know, the weight of the uterus. With 58220, you'll see it's 250 grams or less. 250 grams or less. Okay. And if they say they have a TVH with a salpingo-oophorectomy, you're like, what is that? Salpingo-oophorectomy. Salpingo is going to be the tubes. And the oophorectomy, I always think of the two O's. That is going to be your ovaries. The ovaries are also being removed. So some people come in and they have a TVA, a hysterectomy and a salpingo-oophorectomy. When you hear those two terms, they're having a hysterectomy, the uterus is being removed, and they're also removing the tubes and the ovaries in reference to the hysterectomy. Okay, so we got all of that in there. And look, that was the open approach, guys, right? On page 357, on page 357, you'll see all the codes for laparoscopic. So now you got to ask yourself, with a hysterectomy, is it open or is it laparoscopic? So you know what page to go to. So it's going to be the same thing, just laparoscopic procedures. If you look at 58550, you'll see it just says laparoscopic or laparoscopy surgical with vaginal hysterectomy, uterus 250 grams or less. It's just the approach. And 58553 is where the uterus is greater than 250 grams. And then the 58554 is removal of, they're having the hysterectomy along with the salpingo-oophorectomy. I like to say that word. All right. Same thing, turn to page 358. They have an illustration there. That looks like a very long scope. 58570. That's your total hysterectomy again. That's the laparoscopic hysterectomy. And again, the weight of the uterus. Same thing for page 359. All right, so 58661. 58661 is where you can see those two terms, oophorectomy and salpingojectomy. So they're just cutting the tubes in that one and removing the ovaries. All right. I don't want to use that yet. Let me go back. I want to quiz you on that question. All right. All right. And then your in vitro fertilization, I'm on page 360. 360. And the in vitro fertilization is talking about what's actually being implanted or transferred, either the how they're going to transport the embryo into the uterus, right? So 58974, they're going to place it in the uterus. And 58976, so you make sure you highlight intrauterine is uterus, and then your 58976 is into the fallopian tube. The fallopian tubes. And then we're going to go into maternity care and delivery. So you can see on page 360, continuing on page 361, they give you information about the global period. I want to talk about the global period for a minute. When I talk about it, I think you'll be able to understand it a little better than me trying to read this whole thing to you. So basically, I'm going to talk about some codes, or when they say a global package in maternity, a global package. That means mom has come, she's seen the physician from the beginning of her pregnancy until 6 weeks after she delivers. She's still going to see him, right? So remember, anytime we start to use, if we're in this chapter and we're talking about maternity, these are going to be those O codes in the ICD-10, right? Those are pregnancy codes. If the delivery is not a normal delivery, meaning it's not a vaginal delivery, it's considered to be a complication. Even though it's cesarean, we don't consider it to be a complication. It's considered to be a complication if it's not a vaginal delivery. But back to the global package. So every service that's provided to mom from the time she starts to see the doctor until delivery is considered a global package, right? So if mom comes and she delivers one baby at the end, the global CPT code to use for the delivery is going to be 59400. So right now I am looking on page 362 and start to talk about some of these delivery codes. You can write delivery at the top. Okay, so antepartum is going to be before, right? Postpartum is going to be after. Please remember, as far as ICD-10 goes, mom will still use pregnancy codes up to 6 weeks after delivery. After delivery. So if she gets a urinary tract infection after the baby's like 3 weeks old, mom gets a urinary tract infection, you're still going to code it, right, with the pregnancy complication codes. You would get the complication pregnancy code for urinary tract infection, and then it may tell you to place, to also list the normal urinary tract infection I-10 code, depending on what the coding guideline is. But just remember, you're still using pregnancy code 6 weeks after delivery to report any conditions that mom experiences during that time. Now back to the CPT. CPT code 59400. Okay. Remember, that code is when mom has received all treatment from the beginning to the end from that one doctor, and now she's delivered. She's delivered one baby. 59400. 59409 is delivery only. So there's no, and when I say delivery only, meaning mom could have had care in New York, and by the time she got to Georgia, now it's time to deliver. Her doctor's not here. So the doctor that's in Georgia is only going to deliver the baby. He's not going to get all the money that's involved in a 59400 because he didn't take care of her that whole time. He only delivered, right? So the 594 is the bigger reimbursement, right? So 59400 is when doctor has seen mom the whole time and delivered the baby. 59409 is the delivery only. Or if mom has twins, the vaginal delivery of the second baby, right? Because you can't, 59400 is only for one baby. And you can't have the routine or the global obstetric care. You can't do it twice. It's only once. So you would have to charge or bill for the second baby being delivered, which is 59409 vaginally, or delivery only of the baby. Okay. And if she delivered here in Georgia, and now that she's delivered, the provider can also bill 59410. He can use 59410, which is indented, right? Because it's saying, yeah, I delivered the baby, and I'm also going to take care of her 6 weeks after the baby's delivered. That would be 59410. And as you can see, CPT code 59414 is just the delivery of the placenta, right? We usually don't code for that. I don't know why that would be a separate procedure, unless it's a different type of situation scenario. But you see separate procedures, so you know what modifier would go there. Sure, let's talk about twins again. And I'll talk about twins vaginally, right, which we just did. And on page 363, there's also cesarean delivery. Right. So if mom's delivering vaginally and everything's all good and she's seen the doctor from day one until she delivers baby Bob, just give him a name, they would use 59400. If baby Bob has a sister and the doctor took care of mom the whole time up until delivery, it would be 59400 and 59409 if he's a twin, right? Global for the first, delivery only for that second baby. Different scenario in reference to cesarean deliveries. Okay, with cesarean deliveries, baby is removed Caesar style. That's where that name comes from. Which means there's an incision across the stomach. Baby's delivered that way. If it's the global code for a cesarean delivery is going to be the 59510. 59510 is the global for cesarean. Now, if mom has twins, we don't use 59409 because the incision's already there. So they're like, remove both babies from that one incision. All right, so you can't code it twice or use a 59409. So that's the difference. All right, the 595 is already a complicated procedure, so it's already going to have a high reimbursement. So what they're saying is it's not going to be that much more difficulty to take the baby, the second baby, out of that first incision. Whereas with the vaginal delivery, mom still has to push and do all that extra work. So that's why they're able to code for that extra baby, the 59409. Remember, for cesarean, both babies are going to come out of that one incision. That would be 59510 if mom had the total care. If it's delivery only, if mom was living in another state, came here, if it's delivery only for cesarean, then it's going to be 59514. Okay, 59514. Okay, and sometimes they have, you can see here further down on page 363, they have delivery after previous cesarean. They usually call that VBAC, right? You can see that the first bullet point on the slide, VBAC. And that's vaginal birth after cesarean. What does that mean? That means mom could have delivered kids cesarean, and then when she comes in to deliver her third child, they'll attempt to do a vaginal birth. Usually we would say, okay, well, if they had a cesarean, that's how they need to take it out the next time, deliver the baby next time. But some providers will attempt mom to do a vaginal delivery first, right? But if there is documentation in the record that she had prior children and those children were delivered via cesarean, then you would come and use the delivery after previous cesarean. Okay, so that would be on page 363. Okay, that's the VBAC. All right, so let's see if I thought I had a little question. So here you can see pregnant patient delivers twins, keyword. Pregnant patient delivers twins at 30 weeks. Fetus 2 is delivered vaginally. Fetus 1, cesarean. That sounds like fun. Okay, so what would your answer be? Can someone place it in the chat box? She delivers twins. One's, and let me just tell you something real quick before you put your answer in the chat box. Remember, the cesarean is considered, is more extensive than a vaginal delivery, right? And so before you answer this question, also think about your sequencing. Now, one's delivered vaginally, and one's baby number 2 is delivered vaginally. Baby number 1 is delivered via cesarean, right? So what would we need to do? Because I just threw a curveball in and I told you how to deliver twins, both cesarean, and then I told you how to deliver twins, how to code for delivery of twins vaginally. So now that we have one cesarean, she's just having a great day, right? She has one cesarean and now she's going to deliver the other one vaginally. How would you code that? Which codes would you use? I have a few here. It's not A, B, C, D, so it's not just one answer. Or is it just one answer? Okay, because we got delivery for one baby. I still gonna need the delivery of baby number 2. But your first code, let me, I'm gonna wait for you to put a couple of answers before I explain it. So I see Sharia has an answer. Okay, we got some other volunteers. Yes, I love your answer. Very good. Anybody else want to give it a try? I guess I explained it okay then. All right. So let me explain, because everybody's just like, no, I'm not going to put an answer in the chat box. Okay. So remember, the cesarean is going to trump the vaginal delivery as far as intensiveness, right? Which one has more detail? It's going to be cesarean. So mom has delivered, you could do the global code for the cesarean, right? So you can do your routine 59510 for the cesarean delivery. And then for the additional baby, because it's going to be delivery only, you're going to do your vaginal delivery only, right? That's going to be your 59409. So 595 for the global, because we got to get paid, because he did see mom from beginning to end. And she also delivered 2 babies. Fetus 1 was delivered cesarean, so that's the first way it came out, but cesarean is more difficult than a vaginal delivery, so you're going to list your cesarean code first. And then second was the second twin. And remember, the second twin now is delivered vaginally, so we only can code for the delivery only. Yeah, that was a tricky one. I had to give it to you like that so you have a way to think about it in different ways. In different ways. It is interesting. It is. So you have to think about, remember, cesarean is more extensive than a vaginal delivery. They consider it a complication, actually. Right. So, and that happens. One can be delivered cesarean, one can be delivered vaginally, 2 can be delivered vaginally, 2 can be delivered cesarean. So I like to use the twins because it's easy. If I just say one child, you're going to know, one baby, you're going to know where to go. But when it's twins, the CPT combination changes up a little bit depending on how they have been delivered. Right. Just remember, if both of those babies came out cesarean, it would have only been 59510. But because one was cesarean and one was vaginal, the second for the vaginal one, you only can bill vaginal only. I'm sorry, delivery only. Okay. So I hope that makes sense. And then on page 364, oh my gosh, we're done. Are we done already? Sheesh. On page 364 talks about abortions. Well, it starts at the bottom of 363. It talks about abortions. And it says for surgical treatment of spontaneous abortions, you are to use 59812, which is at the top of page 364. That's for spontaneous abortions. And then it tells you 59820 is for missed abortion. Septic abortion, just make sure you highlight the different types, because you have induced abortion, dilation, evacuation, by injection. And just make sure you have those key terms highlighted. NPR, which is in CPT code 59866. That's multifetal pregnancy reduction. You know, like sometimes moms go in and they get that artificial insemination, and now they got like 8 babies inside of them, and they say, I'm just going to go with 2. So that's for the reduction of the other ones. Right? All right. I'm going to stop there because then we'll be going into the endocrine. I just want to see. And really quick, the last thing I wanted to cover, was anesthesia. And I'm going to show you how easy that is. But before I do that, because I'm not even going to have a screen up to explain anesthesia, I can do that in a couple of minutes. I'm going to open up the line and see if anyone has any questions about what we just covered in reference to the female reproductive system. So you're free to speak. Anyone have any questions? No, nobody? Sure. We got the pregnancy part down packed. Do we understand that? pregnancies? Can I get some yeses in the chat box, possibly?
I do, but I have one quick question in
Sure.
regards to um, the cesarean and the regular delivery.
Okay.
Would it be fair to say that each one, when you're doing these procedures, the most extensive will always be listed first?
Absolutely, because that's how reimbursement is distributed, right? Because you want to make sure you get 100% on your first procedure, and then it's going to be 50% on the second, and then 25 on the third, and whatever follows. So you always want to make sure that the most extensive procedure is listed first, because that's going to be your 100% of reimbursement. And the cesarean pays more than a vaginal delivery.
Okay, thank you.
You're welcome. And someone asked about the abortion. I was just stating, make sure you underline the different types of abortion. Abortion starts at the bottom of page 363, and on page 364, next to CPT code 59812, you want to notate spontaneous abortion. That's a spontaneous abortion, 59812. 59820, you should highlight missed abortion. 59830, septic abortion. And then 59840, you have induced. 59841, you have induced also evacuation. 59850 is going to be by injection. And I jump down to 59866. That's which is not really considered abortion. It's under other procedures, but that's when you're reducing those. For example, I use the eggs when someone gets in vitro. Okay. Any other questions? Alrighty. Lots of information tonight. Lots of info. Last thing before we wrap up is on page, and I do like to do a few examples before we go, don't I? Yep. Let's see, anesthesia. So I'm on page 53. So all the way in the front of the book, beginning with zeros, anesthesia. Tell you a few important things you need to know. Right now, I am looking on page 54. Everybody on page 54. And I'm looking, as you can see, these are green pages. So these green pages are basically guidelines on how to code for this particular section. Your green pages are in the beginning of most of your chapters if they need to explain certain guidelines for that chapter. So I'm on page 54 and I'm looking at the topic where it says time reporting. Time reporting. I need you to put a star next to time reporting, because sometimes they ask, when does anesthesia time start and when does it end? Right? They're going to ask that. Okay. Second sentence. Anesthesia time begins when the anesthesiologist begins to prepare the patient for the induction of anesthesia in the operating room, and ends when the anesthesiologist is no longer in personal attendance. I need you to highlight that in time reporting. That's the first thing I need you to know about anesthesia, when time stops and when it starts. So basically, it's when the anesthesiologist is like, "Hey, I'm here for you," and they stay until they're like, "Okay, bye." That's how long the time. And anesthesia time is billed in increments of 15 minutes. That's not something we cover in here, but I do want you to know that. It's billed in increments of 15 minutes, and there is a formula. Depending, the hospital will have a base rate, or the anesthesiologist group will have a base rate, because usually anesthesiologists are a group all by themselves. And the base rate is going to be, dependent on whatever they say that is. So it's going to be the base plus time plus modifying factors if there's anything else to affect that care. So it's B plus T plus M. I'll send you some additional information on that if you'd like. It's not going to be required for the exam, but there is a formula for anesthesia. All right, so you have when anesthesia time begins and you have when it ends. I am now on page 55. There's a couple of things you need to know when you are coding for anesthesia. There's some steps, so let's get the steps down. Anesthesia coding steps. What do we need to know? And there's also going to be some modifiers that are actually found in your HCPCS, which is how we're going to close the night out tonight, that are actually pertaining to anesthesia. First, I want to talk about page 55, where it has physical status modifiers. So what is a physical status modifier? A physical status modifier is basically the patient's condition at the time of surgery, when the anesthesia is administered, right? That's what their healthy condition is, right? P1, if you're looking at that, P1 is a normal healthy patient, all the way to P6, where the patient is declared brain dead. Okay. And they're going to go in and get their organs removed because they're going to donate them to someone. That's when you use a P6. Right? So P1, normal healthy, P2, mild systemic disease, P3, severe systemic disease. And you're like, well, how am I going to know? Don't worry, because they will say a patient with mild systemic disease. And you're like, oh, okay, that's a P2. Right? So the physical status modifiers basically go at the end of your CPT code or appended to your CPT code. On the right-hand side, you have what they call qualifying circumstances. The most important one we're going to use is maybe going to be that 99100. How do I know when to use that? First thing you need to know for anesthesia coding, how old is my patient? If the patient is under 1 years old or over 70, you will use that add-on code 99100. So you need to know the age of the patient, right? You definitely need to know the age of the patient. That's your first step. Age of patient. Second step, I love anesthesia because it's done by body part. It's separated by body part, right? So you need to know what body part or what body area is anesthesia going to be delivered. Body area. Age of patient. Is there a need for a physical status modifier or a P modifier? Do I need a P modifier or not? Okay. All right. So if you turn to page 56, and I said there was going to be a procedure. Let's see. Remember we were talking about a cleft palate earlier, right? And I said cleft palates are usually going to be procedures performed on babies. Okay. So let's say I had a 6-month-old. Should already be setting off a trigger in your head. A 6-month-old that is coming in for repair of her cleft palate. So remember, we're billing for anesthesia right now. We're not going to do the actual procedure. We're staying in the area where we are. That's another thing you need to remember. If it's anesthesia, then your answer should be coming from anesthesia, right? Because they're talking about, there's going to be 10 anesthesia questions. So they're coming in for a repair of a cleft palate. I said, how old did I say they were? 6 months old. And they also have a mild systemic disease. What would my answer be? 6 months old, coming in for a repair of the cleft palate, and they also have mild systemic disease. First thing I have to ask myself, if I'm talking about a cleft palate, where's my cleft palate? It's the mouth. Where's the mouth located? On the head, right? So you're going to look for head, which is on page 56. We got some coders. Just remember, Artavis, you got the right answer. is right. Just make sure that P2 goes at the end of your first CPT code. That's where that goes. And then you got it totally correct. I knew you guys would like anesthesia. Okay, so how would I write that out? Okay, I said they were 6 months old. If I said they were 6 months old, remember, you have to consider the age of the patient, number one, right? Under 1, over 70, I need to be using 99100, but I know my 99100 is not going to go in the first position because it has that plus sign, and we know that those cannot be listed first. So I'm looking for my procedure, right? And my procedure was being performed on the cleft palate. And for that, you should have CPT code 00172. And I said that the patient also had mild systemic disease. So that means I'm going to have 00172-P2, comma. And then I'm also going to need to indicate that they're under 1 or over 70, right? And with that, that's going to be my 99100, right? So the complete answer, yep, Rochelle has it there, 00172 P2 99100. And it just looked like we did a lot, and we did that in less than 2 minutes, right? So you just got to remember where all your your body parts are. That's what's going to be important. And on page 55, I want to give you some other modifiers I'm going to need you to know that go along with anesthesia that are not located in the CPT. That's what throws people off in the anesthesia section, but I'm going to give them to you so you don't have to worry. First thing I want you to write down is QX, and I'm not going to give you the definitions. Once I talk about, because we're almost wrapped up with anesthesia, once I talk about HCPCS, then you're going to know where to go to get your definitions because they're going to be too long. But I'm going to tell you the modifiers you need to write. And I will also put them in the chat box so you don't miss them. There's QX, QZ, QY, QS, AA, and that's for anesthesia administered by an anesthesiologist. Remember, an anesthesiologist is also a physician. And G8. G8. And that G8 is for monitored anesthesia care. So I've put those in the chat box just in case you didn't grab them all. There they are. QX, QZ, QY, QS, AA, and G8. Right. Also, you have to know what falls in some of these body areas, right? On page 57, page 57, where it says intrathoracic, right next to that, I also want you to write the heart and chest. So the heart and chest are going to be in this area. Right. CPT code, that 00524, that includes the lungs. So make sure you write lungs next to 00524. Okay. What else? Remember on page 56, I spoke about that page in the beginning of the presentation where we had the little image there of the various quadrants. So make sure a little later that you revisit that slide. Let's see. Make sure you revisit that slide and make sure you put those body parts in the certain areas that belong in upper abdomen and lower abdomen. Okay, there is no GC modifier, so that may be incorrect. It maybe should have been G8. Okay. Okay. And where do you want to write those? I would suggest on the same page that you have your that green page where we just spoke about the physical status modifiers and the qualifying circumstances. There's a little piece left down, a little half blank page. I would write them right there. That's a good place for them. On page 57, I'm sorry, not 57, 59, where it has perineum, that's going to be your male and female genitalia. Male and female genitalia. Okay, so you're going to have that there. Where it has upper leg, that's going to be your hip. And you know you're going to get something from there because a lot of Medicare patients always have hip replacements. So you'll maybe get one from that category. Right. Let's see what else I need you to know. Turn to page 61. Page 61, where it has upper arm and elbow. That's where your humerus is located. So just put humerus there. Humerus. And then page, let's see, the last page, which is page 62. The obstetric section is going to be one they'll maybe pull a question from also. And you can see, look, there's anesthesia for vaginal delivery only, CPT code 01960. And then there's anesthesia for cesarean delivery. Look, 01962, anesthesia for urgent hysterectomy following delivery. That's important too. All right. So, I'm going to just give you a strange question. I got a 72-year-old mom that's coming in for a cesarean, and she has severe systemic disease. I don't know how that all goes together, but you get where I'm going with that. So again, 72, cesarean delivery, severe systemic disease. Answer in the chat box. 72, cesarean delivery, severe systemic disease. 72, cesarean delivery, severe systemic disease. What would my answer be? Severe systemic disease. Severe. Okay, again, remember we are in anesthesia, so your answer should not be coming from, we're talking about coding for anesthesia services, not delivery services. So you got to come back to anesthesia. Come back. Come back to anesthesia. Remember, your answer should be coming from the anesthesia section. And I see everyone just popping those answers in there, which are correct. I think you love anesthesia already. Yeah. So the correct answer, I've entered into the box. Perfect. 01961 with your P3 for the severe systemic disease. And then you're going to have a 99100 because the patient is 72. One last thing in anesthesia, and then I'll do hick picks and we're gone for the night. Remember, I told you about the 99100. Under 1, over 70 is when you're going to use it. Just make sure it's not rolled into the CPT code. If you look at CPT code 00836, 00836, it's on page, what book am I in? I'm actually using two books. When I say 00836 is going to be on page 58. If you look at 00836, it tells you in parentheses, see it? Highlight it. Do not report 00836 in conjunction with 99100. It's already rolled up in there. Okay, so make sure that you highlight that. Highlight, put a star. Same thing with the 00834. So it's happening to the babies, because you can notice that they're already stated in there, younger than 1 year, right? It's already there. Or younger than. So if the age is already indicated in the CPT, then you don't need to add it on again because it's already there. That's the same thing I saw. Number 75 on that midterm. Just a few people got it, a few people didn't, because you have to make sure you read the CPT code. It was all rolled up into that CPT, so you didn't need to add that modifier. Yeah, so that's why. So you got to make sure you read in parentheses. All right, and then you got those modifiers that I gave. Last thing I want to do to close out the evening is just to give you a quick review on the HCPCS. I want you to write down, I'm going to tell you, I'm going to type it in the chat box. These, what that I'm typing in the chat box, I need you to tab in your HCPCS. Okay, it's going to be table of drugs. I put that there. G codes, because G codes are Medicare codes and we need to get there quick. All right. And then you're going to also need to tab your modifiers. And depending, everybody's, a lot of people don't have AAPC books, and actually the one I have in front of me right now is a Carol Buck HCPCS, so they're all set up different ways. But you do need to have tabs in those areas, and also for a tab in your index. And J codes. Your J codes are the actual drugs, right? J codes are drugs. All right. So let me tell you how you use this book. Same like the others. Let me get over here. So you're going to have your tab on your index. Oh, this book is great. It has a lot of illustrations in it. So you'll have a tab on your index. And everything's in alphabetical order. So let's say I am looking for orthopedic shoes for arch support. Orthopedic shoes for arch, ARCH support. What would the code range be? The code range. My HCPCS code range for orthopedic shoes with arch support. Remember, you got your index, everything's in alphabetical order. So right now you should be looking for orthopedic shoes, right? And then once you find orthopedic shoes, you're looking for arch support, and you're going to type the code range in the chat box. If everybody, okay, let's see. Can you type in caps too? Because I can't really tell if it's an I or an L. Just make sure you have your caps on. Orthopedic shoes, arch support. Okay, Monica has it. Anybody else? And Toya, I see it. Perfect. Okay. So I'm trying to figure out L3. So you should have your L3040 starting, right? I have until L3100, but I see L3090. Where do you get the L3090? Let me turn to, and then just like you have your index, the middle of the book is going to be considered your tabular, and they're all in alphabetical order. So you can turn to your L30, right? L30, what was it? L3040. L3040, right? Yeah. So don't forget the arch support. It should have gone all the way to L3100. So you would have L3040 to L3100, which is great. Okay, so you understand that part. So that's basically what it is. Oh, let's do a G code. Make sure you have your G's tabbed. Okay, so for a colo patient comes in, she's a Medicare patient, and she's coming in for a colorectal cancer screening. And her mother previously had colon cancer. So patients coming in for a colorectal cancer screening. And her mother also had colon cancer. What would that HCPCS code be? Coming in for a colorectal cancer screening. And when you find that code, you're going to highlight it and put a star. Colorectal cancer screening. Yep, I see Cherie has it there. That's perfect. Anyone else want to give it a try? Anyone else even know how to get there? Remember, it's a screening, right? So you can't look up colorectal. This is not a diagnosis, right? We're looking for what they're coming in. This is the HCPCS book. They're coming in for a screening. So you're going to go to screening first. You're going to go to screening first. And then you're going to look for colorectal cancer. And it's going to give you a code range. G104, G0104 through G0106, right? That's your screening for colorectal. Tells you right there. And then I said that mom had it. So now this patient becomes what? High risk. And the only one they have that states high risk with that category is going to be G0105. G0105. So you see how we got there. Okay. Last thing I wanted to show you in the HCPCS book, make sure you remember how to find your, you should have an index there where it will tell you where your modifiers are, because it's going to be different depending on the book that you have. So make sure you have that tabbed. All right, the last thing I wanted to show was the J codes. So we're just going to turn to, there's a table of drugs. Where's my table of drugs? If I had my tab in here, that's why I said it's important to tab it. All right, so the table of drugs is usually after your index listing, then it will start table of drugs. And the drugs in the book are going to be listed by generic name, not brand, otherwise this would be like a textbook. Okay, So everything in the table of drugs is going to be listed in alphabetical order. Let's just find an easy one everyone can find. Okay, so I'm looking at, if you found the table of drugs, I'm looking at bacillin. I'll put it in the chat box on how it's spelt. So I have given you bacillin CR. I didn't give you a number or anything after that. That's all I gave to you. So in your table of drugs, that's the term that you will look for. And you will see that the dosage for that drug is 100,000 units, right? So let's say in your scenario it said 200,000 units. You would just have 100. You'd have your HCPCS code. Anybody find the HCPCS code before I go into the answer? Ah, you guys are quick. I'm still, okay, there it is. And so that's J0558, which you guys already have in the chat box. And you can see that the dosage, if you look in the dosage column, it tells you it's 100,000 units. They don't have a method of administration, but for the other ones, you can see the various methods on how they can administer that drug. And then you'll see the HCPCS code, right? So 100,000 units is J0558. So if in the scenario, it said that 200,000 units was administered, then you would have J0558 times 2, like so. Right. So that's how that works. So you look at the dosage, look how much is in your scenario, and you would do a times, just kind of like when we did with integumentary. Right? And you can see the one right underneath it, that bacillin CR, where it had 900, 300. You can see it's two codes, two HCPCS codes, but they tell you what those codes are. They tell you what those codes are. Okay. Anyone have any questions for me in reference to the HCPCS and how to use it, since I just did this little brief? There's only 5 questions, right? I can guarantee you it's maybe going to be something about Medicare, like I said. With HCPCS, you don't really have to worry about sequencing, because these are just like, you know, supplies, drugs, and wheelchairs and that type thing. So for that, those are usually billed differently anyway, but you won't have to worry about sequencing for that. You don't have to worry about sequencing for that one. Okay. And I'm just going to open up the line